Welcome to Pharmacy to Dose, the critical care podcast. I'm your host, Nick Peters. Wherever you are and however you are watching and possibly listening, thank you. Thanks for tuning in to the first full YouTube video for Pharmacy to Dose. What more fitting way to open the YouTube channel than to do a deep dive into the ANNEXa-I trial with three of our favorite recurring guests. Scott Dietrich and Brian Gilbert joined me to discuss an overview of the study, balance of safety and efficacy, mailbag questions, questions we still want answers to, practical considerations, much, much more. Plus, a special guest appearance from our favorite statistician, Todd Miano, answering some of the most burning statistical methodologic questions that we have with the ANNEXa-I trial. And then, of course, if you wanted more of an overview into the study itself, not necessarily as much of a deep dive, got about a 30-minute solo podcast in audio format that you can listen to. Now, I'm still learning video editing. You'll probably see as you go through. So let me know what feedback you may have. But I hope you all enjoy and learn as much from this discussion into andexanet alfa and ANNEXa-I as I did. So let's get going. Well, there was so much going on with this trial. Did a quick overview, but now bringing on the experts, recurring guests, friends of the pod to come back and do a deep dive into andexanet alfa and the ANNEXa-I study. Brian Gilbert, Scott Dietrich, Todd Miano. So Brian is an emergency medicine pharmacist at Wesley Medical Center at Gilbert PharmD. Scott, emergency medicine pharmacist with UC Health at Fort Collins, Colorado, the appropriately named at PCC_PharmD. And then Todd, critical care pharmacist and assistant professor of epidemiology at the University of Pennsylvania at Miano 81. Refreshing. You get these young kids on here, man. They don't have any of the Twitter handles or anything like that anymore. Refreshing to get some familiar faces on here. So Brian, Scott, Todd, how's everyone doing today?
Thanks for having me, Nick. Yeah, no, I've got Twitter handle envy of Scott's his handle. It's probably the best out there on Twitter.
I know you're getting offered cash for that right now, Scott.
No offers yet, but I'm open.
I have the least original Twitter handle ever. It's my name. I was born in 1981, and that's it.
So that, like, 81, was that like your, well, they wouldn't have had, did they have, when you were like on AIM or AOL Instant Messenger, was that was like Miano 81? I got to imagine 81 was the number you used at the end of those, right?
Yeah, I mean, I think so, but you're right. Like, I am from like the dinosaur days where, you know, I can remember having a modem and yeah, AOL online.
Hey,
yeah.
I'm an 80s baby. Hey, come on now, raise them up. But we're not that old. We need to chant it. We're not that old.
Tell that to my back.
Oh, I slept wrong on my shoulder. It's hurting for 2 days. I know. Old guys yelling at clouds now is what this has turned into. Okay, so for those, I'm going to do a brief highlight of the ANNEXa-I trial, but obviously if you want more info, had about a 30-minute one doing a deep dive kind of into some of the stats and things. This one will be a little deeper, but if you want more of an overview. So briefly, the ANNEXa-I International Prospective Multicenter Unblinded RCT. It enrolled adult patients with an ICH prescribed factor Xa inhibitor anticoagulant, received their last dose 15 hours pre-randomization. 18 hours was the cutoff in the ANNEXa-4 study, presenting within 6 hours or less of symptom onset. So key exclusion criteria, GCS less than 7, surgery planned within 12 hours, or a thrombotic event 2 weeks pre-enrollment, randomized 1-to-1 to andexanet alfa or usual care. Usual care meaning you could do whatever you want. About 86% of patients got PCC, but there was, in the discussion from the authors, with there being no international standard of care, they didn't think they had to mandate one process in the usual care arm versus another. So The primary composite endpoint, a hemostatic efficacy at 12 hours, defined as three different things: the change in hematoma volume of less than 35%, an increase in NIHSS score of less than 7 points, and no rescue therapies to decompress the hematoma, whether that's like a surgery rescue therapy or like hemostatic pharmacotherapy. So the study stopped for efficacy at the interim analysis with the first 452 patients enrolled. So you'll see the primary efficacy population. That's what that refers to. And then the entire 530 patient cohort used for safety analysis. So as they stopped for the interim analysis, patients are still getting enrolled. That's where that 530 comes in. So 228 usual care, 224 andexanet alfa, and andexanet alfa associated with a significant improvement in hemostatic efficacy, 67 versus 53% to usual care, driven by a change in hematoma volume. Now, andexanet alfa will also significantly associate with an increase in thrombotic events, significant increase in acute ischemic stroke, numerical increase in myocardial infarction. You'll see everywhere, not powered to detect a difference in MRS or mortality. All right. Everyone's on the same page. I think we have to start with this. Why is this topic, the use of andexanet alfa for anticoagulation reversal, and you'd say the ANNEXa-I study itself, why is this so polarizing?
Yeah, I've been trying to wrap my head around this, Nick, and what I have come up with is essentially this is the movie that you walk out of and you're not sure how you feel about it. And then it comes on TBS or TNT like 5 years later, and you give it a watch, and you're like, I don't remember feeling that way about this. And I feel like that's what's going to happen is people have such polarized feelings on this, and sort of that ideal of what a patient that comes in and is in this cohort and how they manage it now. And so we're sort of clinging to our biases a bit and what we feel, whether or not we want the shiny new toy or if we want to cling on to something that's familiar.
Yeah, I think a lot of it is, the biases people had going into the fact before this even come out. Then they, soft launched the results a year ago telling us it's better. And then there's like radio silence for a year after that. So that always, perks up people's ears. Is there something shady going on? And then, the results finally come out and then they are what they are. And everyone's going to, pick a side and then go from there.
Yeah, I also think that we've learned over, like, we've got lots of experience, like being burned, especially in critical care, right? The intensive insulin study comes out and we totally change our practice. And then we realize, well, maybe we should have waited and been a little more circumspect. Activated protein C, the same story there, right? Like there are lots of those stories in critical care. So I think we tend to, we've been conditioned to be even more skeptical now than maybe we have been in the past.
And if we're playing skeptic bingo, right, this is hitting all the boxes. Stopped early for efficacy, some signals of harm, questionable, possibly questionable methodologic changes. I reached out to tons of people before this episode because we're going to work on really giving you what we think is the unbiased true feelings. And one of the things that someone said is, man, they made the mistake of putting the PharmDs against them. They rolled this out. They didn't have any data to support it. It was really high cost. And I said on the other one, it really feels like this study is just putting people into their corners because it's a balance of, it's hard to argue improved efficacy. That's been pretty clear, but you have decreased safety, right? That's a balance. Now, this was a FDA mandated study, right? So the previous andexanet alfa, they used the surrogate factor 10A levels. You may be wondering, like, why would they do that? Well, look at the idarucizumab approval study if you want to see probably why they did that, because other things they've done that in the past. Well, the FDA was saying that's probably not a reasonable surrogate outcome. You need to create this study, and that's why we're here, right? But now I think the question is, what happens with these harm signals? Like, is this going to be the only mandated study, right? Or do you guys think there's going to be more to come?
I
I
don't
think
know.
that was it.
I mean, you can go both ways. If they're just trying to show the FDA that this drug is effective, they can say it's safe in terms of, they didn't show any difference in outcomes from a MRS standpoint. Yeah, there's some signal in the itemized adverse events, but like if the FDA mandated this one study, they did it. I don't know if the FDA is going to come back and say, oh, you need to do another one just from they've already done the one. They're going to say this is probably okay.
So in general, like the first mandate of the FDA is to establish efficacy. So like that's the primary, in terms of when they specify design of phase 3 trials, the first mandate is to establish efficacy. And then if there are safety concerns, some of that will be shifted to like post-marketing. So maybe they mandate additional post-marketing studies that might be observational, where they have to have a registry or something of that nature. But I think I tend to agree that this is not going to change any approval status. I think this is they've established efficacy, as you said.
Yeah, I think this is it too. I agree with both of them. I think they're going to be happy. At least AstraZeneca is going to be happy to let people like our colleagues, Dr. Caitlin Brown and Dr. Paul Dobish, do their work and continue to publish those observational data sets and let people decide from there. But I think that AstraZeneca has purchased it from multiple subsidiaries and has just said, this was it. This was the big finale for them when it came to the quote unquote rollout of andexanet.
In their defense, this is the highest quality study looking at anticoag reversal in terms of it being prospective randomized. You're looking at an actual, we are looking at maybe not the highest level of outcomes, right? But looking at hematoma expansion and not like just factor 10A or, dilute thrombin time levels or things like that. But it was, it's strange. You mentioned that they're going to have database. I think they're already doing that, right? They're having secondary analyses. They had three published before the ANNEXa-I publication was even out. 2 of them at ESOC, right? Comparing the consequences of hematoma expansion and VTE, or predicting who can get a VTE from them. Slow rollout, increased marketing, and I think that kind of goes to the side of us feeling a little scarred. It's like, uh-oh, we've been here. We remember, oh man, I gotta remember Lily, shout out Indianapolis, right? But all that with Zygris and things, I think all of us, guard up a little bit. Now, the other thing, I reached out to a few MSLs that work for AstraZeneca, and I told them, I said, sometimes it feels like there's just a lack of full transparency. I did find out something interesting from 2 kind of independent sources, that not only does AstraZeneca not own this data set, Portola, like the old company, they don't own it. It was one individual who owned it that supposedly just passed away. And essentially what that meant was anytime they wanted to publish or they wanted to include something, they had to ask for permission. I don't know what that looked like. I don't know what they had to look at, but that obviously changes things when you think about lack of full transparency, in a sense, because it's maybe not necessarily AstraZeneca's true wish that this was happening. It's kind of what they're stuck with, it feels like. So that was interesting as we kind of think about that. I've never heard of anything like that. It's probably fairly valuable data set, though, when you think about it.
Yeah, it was the primary investigator, Dr. Connolly, who just passed away. So rest in peace. Certainly, everybody has their feelings about this trial and the data set, but certainly when it comes to the heart of it and knowing that there was a person involved, spending his last little bit on Earth, trying to get this out is remarkable. But for me, when I heard that, because I heard it at ASHP Futures last week, that was kind of an interesting fact of this guy owns the data. Like, is there, who is evaluating this? Is there any sort of quality assurance with that? So it's kind of it raises flags again, not to be the conspiracy theorist pharmacist, but I'll gladly wear my tinfoil hat for that.
I was gonna say, put your foil away. If it wasn't so expensive, do you think we would even be having discussions like this, dissecting every little thing?
I mean, I think we would. I mean, hopefully we're rational people. If it was the same cost or less than PCC would, we would still look at the efficacy data, still look at the safety data, and try and come up with an idea from there. But Protola rolling this out and costing $50,000, like more than double the dose of the PCC dose, like that's just going to set everyone in the wrong kind of camp from the get-go. And then AstraZeneca has to do a lot of digging to make up that ill will that Portola did when they came out with this drug that so many years ago.
Yeah, it does feel like, this went from, it was Alexion initially, then it was Portola, then AstraZeneca. It feels like a little mismanaged, right? You almost think of like the sports analogy, like the quarterback getting drafted to the wrong team. It's kind of what this feels like. And you wonder if they would have had maybe different resources or different ideas from the beginning, what that would look like. Have they put any like cost analyses out or anything? Because obviously the big thing is that to acknowledge that the cost has been dropped by about 50% or so. And that has happened, but have they done any, I'm waiting for those to happen to show like by giving this, you save this much downstream.
Yeah. So they, as an AstraZeneca, reference this poster that was presented at ASHP in 2020. So that was a COVID year. So this was like an e-presentation, but they did this budget analysis where they looked at the total cost of the hospitalization, the ANNEXa arm, the PCC arm, and they showed that there was about a $5,000 reduction in total costs with ANNEXa compared to PCC. And that's mostly because they said the outcomes are better, the length of stay is better, the ICU length of stay is shorter. So in that point, you're going to save about $5,000. But what they don't really say after that is when they look at the inputs of how they got those numbers, it's really, really bad in terms of, it's everything is best case for ANNEXa, everything is worst case for PCC. Like the mortality they put in there was like 15% for ANNEXa and like 50% for PCC, which we know is not even close to accurate at all. So if you're actually using real world, more recent data, put that in there, there's no way that analysis holds up anymore.
Yeah, I mean, it sounds like though that analysis would not hold up with the trial results that we're discussing, right? I don't know that there's any signal of cost. Do they report on length of stay and those types of metrics in this trial? I didn't see those, so I'm wondering. It probably doesn't support. It doesn't support that analysis that you just discussed.
I can't think of any length of stay stuff that I've seen yet.
It's funny.
And for this cohort too, it's a different type of outcome. Like, I mean, a length of stay for a bad head bleed is certainly, like, depending on your resources and ability to get them to a rehab center, which is obviously what they need post acute injury. Now you're dealing with a lot of centers that may have funding issues or insurance issues, and so things like that. For me personally, that type of length of stay, when you're talking about cost and that, it's sort of a drop in the bucket of the initial agent you use, even if it is extremely expensive, one way or another. Just my opinion.
I don't think we're good at doing those cost analyses, and having one department pay something higher that downstream helps the hospital in general, but another, like, it's just not like, we're not streamlined, I don't think, to truly do those analyses in an effective way. Because if we started using all these and length of stay goes down, that's great. But all of us have been in those meetings where it's like, okay, what can we do to reduce our budget? What can we do? Like, that's in direct conflict with that. So I kind of see both sides of those.
How do the data analysis after they get a stroke from
Yeah.
Well, we'll talk about a unique management strategy if that does happen. We'll highlight that a little bit later. Now, into the primary outcome, right? Hemostatic efficacy versus MRS or mortality. So let's kind of there are some, almost different ways of thinking about it. So on one hand, you could say no other therapies have improved functional outcomes, right? What would your response be if somebody said, why should andexanet alpha be held to that standard when PCCs, idarucizumab, they haven't shown that improvement. So why should we need to?
I think it's just kind of like we talked about earlier. When you're the new one coming to town, you have the burden of proof to prove that you're superior to what we were doing before, whether that's right or wrong. But it's not like we think PCC is an inferior product and we've been waiting so long for something better to come along. Most people think that PCC does a pretty good job of what it's supposed to do, even though it's not specific for what it's reversing. But when you have something that most people think works pretty well, when you're coming in, you better be able to blow them away and show that you have a superior product. And I don't think that's been settled just yet, but a lot of it's bias that we have beforehand, some of the ill will that was created. So, they definitely have the burden of proof to prove that they're better.
And yeah, I agree with Scott. I don't think it's I don't think it's fair, or to be honest, on the balance side of this, I don't think it is actually fair what our standard for this drug has been in terms of the anticipation of it. Like I don't, and sort of our expectations of what it should do. I think that when you look at it mechanistically, it does exactly what it's supposed to do. Now, does it do it better? I would say no. I'm with Scott in that PCC is not an inferior product, at least in my opinion. It does exactly what we intended it to do, and it's just maybe not fair from that perspective. But with all of the other outside influences of cost and sort of the weird rollout process, it has left a little bit of a bad taste in a lot of people's mouths.
Yeah, I think it also raises questions about, and questions that we never had answers to, is what is the value in terms of outcome of reversing the anticoagulation? And it seems that it is reversing the anticoagulation may be better, but that is not translating into, dramatic differences in the ultimate outcomes that you care about. What is the value of the hematoma volume that's or achieving hemostatic efficacy, as you mentioned, in these patients where their outcome is already really bad and they're going to be in long-term care for a long time, the impact on that ultimate outcome of this thing that was evaluated at 12 hours at presentation, I think it begs the question, what is that? That's a surrogate endpoint that we don't care about directly. We care about it because we think it translates to the downstream things, but what is the relationship between that surrogate marker at 12 hours and the things that we ultimately care about?
Like it's a risk factor, right? Like they reference in if you meet with any of the AstraZeneca folks, I don't think this is a secret, they'll show you a PowerPoint and share it with you. And they reference 3 studies showing why they kind of chose hemostatic efficacy, why they chose those things. One of them was in the INTERACT-1 sub-analysis, and the other are post-hoc studies from the FAST trial looking at NOVA-7, which is that's the classic example if we're thinking of changing volumes but not changing outcomes. That was the first one. So the question I always come back to is, we know it is a risk factor. Is it actually a modifiable risk factor? Like Scott, what was the analogy you referenced in this compared to kind of like the cardiac arrest population? Because I thought it really is a fairly perfect analogy for what I'm feeling with this stuff.
Yeah, we were talking earlier. It's kind of like ROSC and cardiac arrest, and the drug here is epinephrine. Like you have to get ROSC if you're going to have any improvement in neurostatus, neurofunctions, anything like that. But more literature is coming through showing that epi definitely does improve ROSC, but downstream from that, like it's not doing anything better. So are we thinking of hemostatic efficacy doesn't translate into any patient-oriented outcomes down the line? I know it's hard because you need one to get the other, but what do you do trying to get the one?
Yeah, I think that is a perfect analogy. And the thing in the trial, the benefit was based on this surrogate endpoint that we're not sure what it means, but the adverse effects were not surrogate endpoints, right? They were things that we definitely care about. What was striking is that the increased thrombotic events were arterial events, things, MI, stroke. If it were just increased risk of DVT, maybe we would think about that differently. But if you're causing more strokes and more MIs, that seems very important.
Especially as we're having our an increased interest in long-term outcomes and what happens to them after they leave the ICU. That becomes even more of a point. Brian, I think I cut you off again there.
No, you're good. I think I just wanted to echo what they said and sort of summarize it based off an awesome tweet that Andy Webb had. Essentially, with andexanet alfa, I think you're trading short-term wins for long-term uncertainty.
That's a really good way to say it, because it is that balance of efficacy and safety. And you mentioned surrogate endpoints. The whole reason that we're doing the ANNEXa-I trial is because the initial surrogate, the anti-factor 10A levels, and we'll toss in a few mailbag questions here. One of the questions we got was, when you look at the supplementary appendix, you'll see that for example, rivaroxaban may have a higher factor 10A level in the usual care group than the andexanet alfa group. And one of the biggest things that I learned from all of this is that we don't have any correlation with anti-factor 10A levels for hemostatic efficacy. They had low levels when patients came in. Some patients had hemostatic efficacy. Their levels were still high, not even detectable. So, they were initially chosen to be the most relevant, like biochemical kind of marker to evaluate anticoag reversal. And it's kind of been scrapped for ETP and thrombin generation, endogenous thrombin potential. That's kind of what you'll hear a lot of the kind of reps and things talk about. Now, the other thing that stood out from some of the folks I talked to, a lot of the people backing andexanet alfa just don't believe in PCC. They don't believe it does anything. And that's why they think that this drug is so important. And that kind of stood out to me. That was from physicians and pharmacists kind of involved on the other side of this. So that's kind of an interesting perspective. Now,
well,
speaking of, go ahead.
That is them pushing ANNEXa. So their job is to show you that one is inferior to the other. And they're going to say it's non-specific. There's plenty of data that we could get into showing, thrombin generation differences between the two. And so that's their job, is to make the old one say it doesn't work. This is why it doesn't work. We have this new one that does work, and this is why.
Devil's advocate, is that the MSL's job, though?
Exactly. That's 100% their job. That's what they're hired to do, is show you their data and prove to you why the previous data is either lacking or suboptimal or inferior.
The ones that I have talked to feel strongly that is not that is what they hear, and that is not their job, and they're just trying to give you information. I'm only saying this to try to just play both. I'm not trying to contradict everything you're saying, Scott. I'm just trying to make sure both sides are at least being talked about. That's kind of their perspective. I don't necessarily know, right? I'm not in those meetings and things, but that is kind of their side of that coin.
I do think it's a reasonable question to say, does PCC, what is the effect of PCC? Because we don't have an RCT, a placebo-controlled RCT to say PCC is effective. And that would be really the only way to know that. But we could never do that trial. I don't know that there would ever be clinical equipoise to support enrollment into that trial. So in some ways, it's a bit of a moot point, because I think often you're going to give something. And so, and PCC's, kind of become the standard of care now.
They do have some of those trials, but low risk, small bleeds, no deficits, where it's placebo versus PCC. And in a AZ slide deck, they include one of those studies showing that there was no difference in outcomes between placebo and PCC. And so that's them kind of saying that, like, maybe this drug doesn't do anything. But I think it's more of the patients they enrolled are really low risk, small bleeds. So like giving something's not going to change anything anyway. But there are some of these studies that AstraZeneca, are pointing to saying PCC versus placebo, there's no difference.
There's actually an ongoing phase 3 trial with Octapharma looking at their product, Balfaxar and factor Xa inhibitors. They're primarily looking at dosing of it, 25 versus 50 units per kilo, and it's going to be placebo arm versus the Balfaxar product. So hopefully we get at least a ANNEXa-4 type study with Balfaxar. That should be able to hopefully, I think they stopped the trial in February, so hopefully we get something within the next few months, depending on where they're trying to take it. Yeah, I think there's something in the works similar to that for factor Xa inhibitor, quote unquote, reversal.
That's interesting. All right, let's take a quick break, and then Todd's going to come back and talk to us about some of these outstanding statistical questions that are at the top of our minds when we're reading the ANNEXa-I trial. Introduction, and he is the quote unquote podcast stats dude. That is a quote unquote nickname that we got to call our favorite statistician on the show, Todd Miano. And when we're talking about some of these complicated stats that I think some of us have questions about, feels like it means something, but maybe not. So let's call in the expert here. Todd, how are you, man? How's the East Coast? Is it always sunny in Philly right now?
It's sunny. It's great. It's almost too sunny. It's going to be like 98 today. So
yeah,
we need some clouds, actually.
Yeah. So when we've started, for the listeners to know, I think Todd could probably talk an hour about all the stats that are included in here. We're trying to narrow it down to what we thought are some of our key questions, or things that would help us understand and how to more kind of look at the results and incorporate them. So the first things first, I think, is the p-value change. And how does the recalculation of sample size and the p-value used in the interim analysis, how does that affect our understanding or interpretation of these results, understanding that we stopped the trial early for efficacy as well, with this change in the interim power calculation?
Yeah, so I think this is one of the more important things to think about in interpreting this trial. I think, and it's when you see all these changes, your antenna goes off. You're like, what's going on? Why are they making all these changes? And so I think it's helpful to kind of put yourself in the place of the investigators. So, if you've ever done research, best practice is to plan everything out in advance and think about everything that could possibly happen, and then follow, your plan as closely as possible. And even in observational retrospective research, that's hard to do, right? You try to make the best plan that you do, but then once you get into the data, you find things that you didn't expect and you need to adapt. And it's even more so in prospective research in clinical trials. So you do the best that you can to plan, but then, as they start enrolling patients, they start seeing things. It seems as if they were responding to, new information and realized that our protocol had problems, had weaknesses that we needed to adjust. And it also seems like they received feedback from like regulatory agencies. So it seems like they were having meetings with the FDA and they were like, well, we don't like the interim analysis thresholds that you proposed. So I think there was some feedback there. But also I think they were responding to new data. So if you look at the original sample size and the data that they were citing, there was a number of observational studies cited estimating the effect of PCC. And that is really the driver They felt like they were going to see 80% success with their drug based on the prior data. And so it's really what was their estimate for PCC? In the first sample size estimation, they were estimating about 65%. And then, as they started the trial, they started enrolling patients. More studies came out. Some of our colleagues, Morgan Jones' paper in Circulation was a key driver that estimated PCC's efficacy was around 80% in that study. And so I think they realized we have made a mistake, or we're underestimating the potential benefit of PCC. And if that's true, then their original sample size of 440 patients would not be large enough to detect the difference that was actually there. So I think they saw that data and they said, we need to re-estimate our sample size. Now, there is nothing wrong with that if you make those decisions without looking at the results in your study. So that's these changes after we've launched the trial can be problematic and sources of bias if you look at your results and you say, ooh, here's the difference. The difference is not what we thought. Let's change the trial to maximize the difference. That's like data-driven post hoc changes that can be sources of bias and problematic. But if you are enrolling subjects and 3 new studies come out and you realize our projections of the effect of PCC are too low, our trial is going to be underpowered, and an underpowered trial is going to fail, and you adapt to that, that's a reasonable change. So they didn't change they didn't propose to change to lower their sample size. More data is always better. So they ended up enrolling more patients, even with the interim analysis, than they had originally proposed to enroll. So I think, and then, beyond the change in the p-values, they list out, seemingly dozens and dozens of changes to the protocol.
Yes.
And which can kind of get your attention. You're like, what's going on here? Is there anything fishy? Why are all these changes? And so you somewhat need to put yourself into the mind of the investigators for what is the rationale for all these changes. But I do think that, as I mentioned, in prospective research, there are always unanticipated things that you need to react to. So these types of changes are going on all the time. And so when you see that list of changes, one take could be, that seems fishy. Why are all the changes? Another take is they are telling us every single thing that they changed. And some of the changes were just like rewording of things, like not even them, but it didn't even really change what they were doing. It was just how they worded it in the documentation. So I feel comfortable with the information that is presented. And again, whether or not there were motivations for some of those changes, that it's hard to say. But
he said, she said thing at that point.
Taking it on its face, seeing the changes that they made, as long as those changes were done without the guidance of looking at the results and letting those guide the changes. If they were, just responding to new information, responding from feedback from people who were enrolling, saying, this protocol is not working, this is a logistical problem, then those types of changes are, can all be above board.
Yeah, I see both sides, right? Because our research and our understanding into the management of ICH in general, right, grew a lot from when they started recruiting or started the study idea till now. On the other side, we know they published 3 separate, cohorts from the same ANNEXa-4 study. So that would make the argument maybe they did looks, right? So we won't necessarily know. Now, with it stopping early, for efficacy, are you more likely to under or overestimate your effect in those cases?
Yeah, so I think with all that being said that we discussed, one key thing to know is that in general, across the board, when a trial is stopped early for benefit, it will tend to overestimate the magnitude, overestimate the effect size. And so that's just across the board. So anytime a trial is enrolling patients and you're estimating a given effect of an intervention, as patients are enrolling, there's random variation around that true effect. It's bouncing up, it's bouncing down. So it's randomly overestimating, randomly underestimating. And so if your stopping criterion is based on a signal of benefit, then that stoppage is most likely to happen when when the effect size is randomly high. So that just generally leads to trial stopped early will overestimate the true underlying benefit. And it's related to smaller sample sizes have more variability than larger sample sizes. And so when a small study has a significant p-value, it means that the effect had to be very large because you have a small sample size. And that signal of effect is a mixture of the true effect and random variation. So smaller sample sizes overestimate effect sizes relative to large sample sizes. So it's kind of that same principle. Now, the magnitude of overestimation, there's debate in terms of how important that is. And it does somewhat relate to the stopping criterions that you use. I don't know that I have a problem with, the particular criteria that they use, that those seemed reasonable. I think for the reader, it's more important to just realize that stopping trials early may overestimate the benefit. So if they would have ended up enrolling all 900 patients, the effect estimate reported in the trial was what, 12 or 13% difference in hemostatic efficacy. That maybe if we enrolled all 900 patients, it wouldn't have been 12%, it would have been 8%, or, it likely would be somewhat smaller. And you kind of see that in they reported the results of the patients who were accrued at the time that they said, we're going to do the interim analysis today, right? And so they had enrolled 400 and some patients at that time. But then they report the results from all the patients, from the time that they said, we're going to do the enrollment now, or we're going to do the interim analysis today. They had enrolled in another, 40 or 50, 60 some patients.
I think it was 72. I think I remember right.
Yeah. So the final sample size was around 530. And if you look at the effect in that sample size, it was a little bit smaller. It dropped from 12, 13% down to around 11%. So I think you can look at the results, and I think they are legitimate results, just recognizing they may be somewhat of an overestimate.
And being clear for the listener, we're not saying that these are overestimated, findings here. We're just saying we're talking about statistics and probability and talking about likelihood of if you stop early, just kind of generally speaking. So the other big thing that from a kind of statistics thing that stood out to me was they, in the protocol amendments, they changed to using the apologies in advance when I butchered this name, the Cochran-Mantel-Hansel test, and not like a more simplified test like the Fisher's exact when they kind of talked about in the beginning. So I know that this is not necessarily true, but I generally err on the KISS method. The more simpler the the statistics, if I understand it, the more likely that this is kind of above board in a sense. But I know that there are very valid statistics tests that I'm just not smart enough to understand. So is this a good reasoning, kind of using this different test from the ones more of us are probably familiar with?
Yeah, so I think the rationale for that change was related to the fact that they changed their randomization scheme. So originally it was just a simple randomization. And then with the protocol change, they shifted to a stratified randomization. So they stratified their randomization by time to treatment, I believe, or it was like a time from a presentation to the scan, or time to the first. Yeah, I think it was time to the first scan, which seems like, it's likely a relevant it's a relevant clinical factor that might affect outcome, right? So, and it's something that, especially in smaller sample sizes, even though you have a randomized trial, over time, there can be chance imbalances, especially when you're doing interim looks, right? So we're going to randomize 900 patients, but we're going to look early. And at that early time point, there may have not been enough patients randomized for everything to balance out perfectly. So one way to account for that is to stratify your randomization. So, and what that means is, instead of just each person that shows up, I flip a coin, it's each person shows up, and then I say, what was your time to presentation? Was it above or below? And then I have a separate coin flip that is kind of matched on that stratification factor. And so what it does is it ensures balance on that factor. So now you have a stratified randomization, and your statistical analysis needs to account for that randomization. A chi-square test is an overall test, and there aren't versions of the chi or the Fisher's exact that are stratified. So the Cochran-Mantel-Hansel is a test for yes/no outcomes that can be stratified. You can think of it as like adjustment. So instead of this Cochran-Mantel-Hansel, you could have done a logistic regression where you adjust for the stratification factor. So what that test is doing is adjusting for the stratification, which is appropriate. So I think that was the rationale for the change.
Todd, thanks for trying to help us make sense of these statistics. It's always good to have the perspective of somebody much smarter than us in this field to help us understand that. And you clarified a lot of it, that a lot of it there is real theory and logic behind it. And even though I think on the surface it may look questionable having all these changes, I think that's a really good perspective that you had of, it's probably not all in that sense. There's probably some, X, Y, or Z happening. So always appreciate you coming on and shedding light, my friend. We appreciate you, man. Thanks.
Yeah, man. Thanks for having me.
All right, Todd, that was awesome. Thank you for helping break down some of those stats for us. Now we just kind of talked about the primary outcome, talking about the efficacy. Let's dive into the safety here. I think the first thing, is there any supposed mechanism with andexanet alfa that would explain an increased thrombosis risk, where that would make sense physiologically from the drug itself?
So the AstraZeneca people will say no, from some of the data they've shown when they give really, really high doses to healthy patients, dosing way higher than they give now, they'll say that they didn't see any, increased clot risk and things like that. They constantly say this is specific to the drug. It's not doing anything else to any other ones. If you were to give ANNEXa to somebody who didn't have a 10A on board, it wouldn't, increase their clot risk. And so, mechanistically, it's kind of hard to disagree with that. It's just a decoy protein that's binding a 10A inhibitor that's in the serum. And so if there's nothing there to bind, it's hard to say like it's not going to do anything. But every single piece of data that's come out, whether it's AZ funded or not, there is a 10% risk over and over and over and over and over again.
Yeah, so mechanistically, when you look at it too, I mean, so obviously these patients are prothrombotic initially, and that's why they're on the product itself. And then you've also got the sort of sub-mechanism, which is the tissue factor pathway inhibitor, this TFPI, which is essentially just ultimately going to cause platelet aggregation. And so I think that's where it makes sense of this sub-mechanism and where you see arterial clots as well.
Well, and that TFBI inhibition, right? It leads to elevated thrombin generation. And like you said, you can find this all in the FDA accelerated approval letter, but it says Portola has claimed that Andexxa has no procoagulant activity, but then Portola acknowledged that the increased thrombin generation can be explained by the effect of Andexxa on TFPI. We're supposed to have more detail into that. And that's the big thing, Scott. You mentioned that the rates have kind of maintained, right? The ANNEXa-4 10%. And the big thing to keep in mind with when people reference the ANNEXa-A and R and some of those those are healthy volunteers, which more and more is looking like, extrapolating the evidence from those patients who are sick, especially ICH patients. Those are just two very, very different things in a sense, right? Now what did Scott, they had some interesting data showing specific risk factors for arterial thromboembolism. What did they specifically find there?
Yeah, so this is like some post hoc from ANNEXa-I, and they had prior MI history was a significant risk. The hazard ratio of 2.47 was for arterial thromboembolic events, and then they said eligibility for a high dose of ANNEXa. So if you were someone who would fall into the bucket of requiring high dose, that would be another significant risk factor for arterial events.
So the other thing that's happening with these arterial and just thrombotic events in general is now kind of coming to light some VTE prophylaxis things. And so I've seen some slides that show the rates with VTE prophylaxis and without VTE prophylaxis. And it was kind of startling when you see the difference in those when you do not restart their prophylaxis. Those rates were really high.
Yeah, slide I've tweeted out. I'm sure hopefully everyone's seen it. But you take the general population, it was like 10% with ANNEXa, like 5 or 6 with PCC, and then they showed the slide of they take anyone who got any dose of an anticoagulant for prophylaxis, and then they show the rates of VTE in those groups, and it's 4.9 with ANNEXa and 4.8 with 4-PCC. So then they say, if you are able to VTE prophylaxis people, you really decrease that risk, and then you say, okay, that looks pretty good. If we can do that, maybe we'll mitigate all these negative effects. We'll get the hematostasis that we want. Everyone's happy. And then you read in the footnote that there's a subset of patients who didn't get any prophylaxis during their hospitalization, and the event rate was 30% in the ANNEXa arm, and it was only 7.7% in the usual care arm. So that 7% with PCC we see all the time is there. If you don't get prophylaxis, maybe it's as high as 1 in 3 that you're going to have an event.
And who are the patients that are getting reversed, and then we're able to we feel comfortable enough to restart DVT prophylaxis, and then compare those patients to those that were like, we don't feel comfortable starting DVT prophylaxis, right? Those are dramatically two different groups. And the folks that are getting DVT prophylaxis are probably looking good. They're probably doing better. Their bleed risk is lower. So it seems like there's a lot of confounding by indication there that could be bias in that analysis.
Well, the other
even
big
worse
thing
is you end up in that cohort that your bleed expands, and then you also get an arterial stroke afterwards because you couldn't VTE prophylax. So totally agree with both of you on that.
Yeah, there's a couple good points that people made on Twitter that like VTE prophylaxis is not going to prevent arterial events. And then, some of the conversation of, there are some centers, academic high-level centers that do this all the time that are much better about starting VTE prophylaxis, very soon after patients bleed, they're stabilized versus some of us in the community setting where our neurosurgeons might not feel as comfortable starting it that quickly, and there might be a delay. And does that, maybe a few day difference change outcomes or anything like that? And we don't know that.
That is the point that I wanted to make, Scott, is that some of the discussion on Twitter, people were acting like VT prophylaxis not getting started at 48 hours. That's like, you're not giving beta blockers after an MI. And I think it really is very different when you go from like an academic setting to a more community setting with that VTE prophylaxis. And I didn't even think about that. Is a really good point of, would VT prophylaxis actually prevent strokes or MIs? That is a good point. And then another question, what effect did COVID have? Right. And that kind of makes sense, right? COVID kind of increases your possible thrombotic rate. So unclear. No data was collected on COVID-19 at page 255 in the appendix. In summary, then the conditions set by our eligibility, COVID is unlikely to have altered participants' clinical presentation for ICH. So the argument to not collect it was that's not going to affect or impact your bleed, and maybe logistically would have been challenging. But I think with that thromboembolic rate, I'm sure they wish they had some COVID data to look at and analyze from that perspective. Another group that's going to have like a high thrombotic risk is going to be our surgical patients. And when you kind of dive in here, what's our vibes on using andexanet alfa in the surgical population? Because I don't think there's as much of an argument as there is in our ICH population.
Yeah, there's more and more reports coming out that this is a sort of touted when it first came out as the universal, or one of the universal reversal agents. And so there's more and more reports coming out about its causing heparin resistance, and potentially leading to increases in thrombotic events in that cohort. So definitely a patient population I would not feel comfortable with. And there's a small subset of data with the ANNEXa-I trial that came out that was actually stopped early due to the significant events. I know you're wanting to, I see you chomping at the bits to get into that, but yeah, definitely not a population I would feel comfortable with knowing if they're having to go and have an emergent surgical event to utilize.
Are you saying this is all surgery, or just surgeries like cardiac surgery, which require a bunch of, heparinization?
I mean, just all surgeries from the ANNEXa-I trial. So,
but that is a different. In this study, the way they did it, the bolus in that was to start 30 minutes before the incision. And then you had the andexanet infusion happening for the entire duration of the surgery. Even if it went longer than 2 hours, you just extended the infusion. There was a pharmacotherapy article, I think from University of Cincinnati, that showed kind of their retrospect observational, but showing that in their use, like we would classically use it for reversal pre-surgery, that they showed that it was effective. But I think that's likely why surgery, it's been an exclusion criteria for ANNEXa-4 and ANNEXa-I. And you mentioned that heparin resistance. It makes sense, right? It's a decoy factor 10A molecule. So not only is it going to bind the anti-10A drug, it's also going to compete for the heparin antithrombin complex. So in kind of leading to that heparin resistance. What are...
quick question. If it causes heparin resistance, then how are you going to protect from thrombosis by giving DVT prophylaxis? It seems like that...
Probably the half-life there, but yeah, I mean,
I don't think they know the time frame. So I think by the time you would start VTE prophylaxis, that effect probably would wear off, but not wear off when your like heart is stopped on the bypass machine. And I think that's the problem. Brian, is that your kind of understanding?
Yeah, I think it's probably having to do with the half-life, that you've cleared the decoy by then, and to be able to. But I mean, that's a valid point. For some of these places that maybe there's some residual effects, but I was thinking about it, and the more, and we've talked about like even going back to the COVID thing, it's like still no matter, and Scott made the great point of 10% thrombotic rates every single study. Like I can't remember, like they are accurate and precise with that, you know. So it's one of those that's kind of a weird phenomena to explain. But yeah, the VT prophylaxis restarting, I didn't even think about that. That's a great point, Todd.
So one of the things that I was thinking of too, right, when we're saying something has some increased efficacy, but maybe we're worried about the safety is, have you all thought about any possible strategies to maybe reduce thrombotic risk? Like, can we modify the dosing? Can we exclude certain patients? Have any ideas kind of come to your mind? Because I see these ideas coming as well as a way to maybe still get the efficacy benefit, but try to reduce the risks of it long term.
I mean, I think it's a little complicated. You know, things like BCC came out for warfarin reversal, huge doses. Then we started reducing the dose, seeing that it works fine. You know, if you look at ANNEXa-A and R, they did a bolus, no infusion, bolus with infusion dosing. You look at 10A, it looks like crap with the bolus and no infusion, but you know, we're learning that 10A maybe doesn't matter that much. AstraZeneca says that one molecule 10A can make hundreds of copies of thrombin. So if you have some 10A inhibition around, or you know, you're blocking that, you get this thrombin, and that's fine. And then in ANNEXa-A and R, when you look at the thrombin, if you give the bolus, the 10A goes back to normal, but the thrombin generation is still pretty stable for several hours after that. So, you know, I don't know who's going to have the cojones to run an ANNEXa trial just giving a bolus only, but you know, that would be the only thing I could think of, is just to try to give the single dose, block them up for a few hours, generate that thrombin, and then, you know, see downstream if that has any effect.
Maybe not using high dose came to my mind. You know, I think that, you know, one of those slides we saw that MI was a risk factor, but I think we saw patients eligible for the high dose was also a risk factor. So I agree, it's going to be hard to study, but that's kind of where I'm wondering now is, are you going to start to maybe exclude patients who have like a history of some of those arterial thromboembolism events? You know, we hinted at this, but there's an extreme workaround. Scott, what was this case report that was a very strange setting that this case report was published from?
So there's some ongoing study apparently, but it's looking at someone's on a 10A inhibitor. You give them ANNEXa, they're having an ischemic stroke, so they wouldn't be eligible for TPA. So you give them the ANNEXa, and then you give them TPA. Mind-boggling and wild. And so, you know, there's been a few case reports. This is like the highest risk of publication bias I could ever think of. Like, you're not going to publish, we reversed this person, gave them TPA, they had a massive bleed and died. Like, no one's ever going to publish that. So, you know, seeing these like single isolated case reports saying someone was on a anticoagulant, we reversed it, gave them TPA, they had a great outcome. Well, of course we're going to publish that. So published an isolated case report from that study showing that it worked. So, you know, we've all been skeptical before. I'm very skeptical of this. And so, you know, I would never, ever recommend this for anybody, but, you know, someone's looking at it.
Yeah, publishing
ethics and compliance has entered the chat.
Have you ever heard that? I've never heard of publishing case reports or case series from an ongoing research study.
That's wild.
Yeah, if you're curious, it's called the STROACT study. So because you know me, I had to figure out how they did this, right? So they gave the bolus, took 27 minutes. Then they did the IV TPA, the 10% bolus and infusion. And when they started the TPA infusion, that's when they started the ANDEXA infusion. It's kind of like we're gonna thicken. The right answer is right in the middle. It's a phase 2 Polish study for those interested, but feels like more of an extreme workaround. Hilarious that this is a stroke on oral anticoagulants for thrombolysis STROACT study. So
I have one question for the experts about dosing. Could you imagine a scenario where you start an infusion and you titrate it to some like therapeutic window, like we do with heparin or something, where I don't know if there exists monitoring capacity to like capture the effect and something to target, but that seems like something that could be interesting.
So most centers are not going to have any sort of way of monitoring endogenous thrombin potential. So I don't think so. And if we are saying that anti-10A activity really doesn't matter, that would have been probably the easiest marker. But unless you can correlate those two, which they don't, and the data has demonstrated that with the ANNEXa-4, I'm not sure that we have that capacity currently.
Yeah, it's not like you're gonna pull serum levels every 15 minutes and run like the serum concentration of active drug or thrombin. It'll just be too complicated, unfortunately.
Any role for TEG there, Brian, you think? Or is that in the early? I haven't seen any reports on TEG use with this. Have you any info there, or would that be in its infant stages? I see your head shaking now.
No, I haven't seen anything that I'm aware of on that. Yeah, I'd have to do some digging, but yeah, no, I don't want to mix my tag with Indexa. Don't sully tag for me.
So let's go into the unpublished but not confidential info. So a couple of kind of questions that came through. Why did they choose the 12-hour time frame for hemostatic efficacy? That was the FDA. The FDA was working with them, and that was part of their guidance in terms of why that was chosen. So that's the only thing I've gotten from there. Now, when you look at the early trial design or early versions of the protocol, it said that patients could be enrolled based on time when they took their last dose, meaning 15 hours or less, or based on anti-factor 10A levels. But essentially, the drug levels were more research. So they were central labs. They were more retrospectively drawn. They weren't getting local levels, which they would use for clinical guidance. So all patients were enrolled based on time they last took their medication. And all the others were kind of more retrospective, done for research. Sure, we'll find things from there. The other thing that stood out was the MRS 0 to 3 rather than 0 to 2. Meaning they're targeting an MRS of 0 to 3, whereas in standard, a lot of times you see 0 to 2 as a good outcome. And essentially, it is using what some of the other ICH studies did. So the argument is, look at the ATAC-2 study. They did targeting an MRS of 4 to 6. True. The Interact-2 study did do death or disability targeting 3 to 6 on the MRS scale. So, but they're kind of saying we didn't want to necessarily reinvent the wheel. It's not validated. So that's where those three kind of came in. Any other? I think we've all been kind of meeting and talking with some folks about this. Any other kind of highlights from like an unpublished info you want to, but not confidential, that you want to let the listeners in on? Let's get in here to questions that remain. So the first thing to me is the usual care patient characteristics. I think that's what we're all looking for. What did these patients look like, right? And is there any info in terms of what the usual care group looked like really at all from a demographic or treatments received perspective?
So the interesting about, the usual care group, a lot of people knock them saying that like 15% had no treatment. And the reason behind that is since PCC is not FDA approved, they can't make people in a study give something that's not FDA approved. So that's why, it's up to the treating clinician whether they want to reverse them or not. So then you get this question of what did those patients who did not get PCC look like compared to the PCC ones, compared to the ANNEXa group. I interpreted as these were smaller bleeds. Their GCS was 15. So I interpreted as small bleeds, no deficits. The team decided not to give it. Some other people out there like Ryan Radecki, who has EM lit of note, his kind of thing was he thinks that didn't get PCC was, quote, disadvantaged by not getting any treatment. So it's kind of unclear. There's a forest plot in ANNEXa-I. The very bottom part, they have PCC and then like no treatment compared to ANNEXa. And the PCC group did worse. The people who got nothing did just as good as ANNEXa. So that again leads me to believe that those patients are probably low risk going into the trial.
I think what makes it hard for me is that the discussion coming into this was, one of the lead authors, Ashkan Showamanesh, was saying he doesn't believe in PCC, and that most of the other researchers, he had to beg them to use PCC essentially. And it sounds like in the beginning, the usual care arm, they weren't getting much. And so to me, that's where when you say things like that, initially, I thought what you were thinking, Scott, is those were the blips. We're arguing against reversing it all. Whereas now, right, when you say statements like that, it makes me think maybe they weren't. Maybe these actually were patients that had bleeds that could have done something, but didn't get PCC for one reason or another. The problem is we're all guessing, right? We just don't know. And that's the problem in that.
Also, what year is it that we're still using 3-factor PCC when 4-factor exists? There was like 3% of the patient population that did that too. And we know just from INR and thrombin potential that you're going to get essentially more activity with a 4-factor. So that also was like kind of in my head. I'm like, why the hell are we doing this?
And another thing kind of with that is, what rescue hemostatic agents were administered. We kind of figured out the breakdown, not much was given in either of the groups, but kind of a wide range of like burrow hole drainage versus just getting TXA or something. So kind of seeing what that breakdown would be nice. Other thing, and there was a deluge, it feels like, of information, of observational data. And how do we apply and interpret those pre-ANNEXa-I data and systematic reviews and meta-analyses now that we have the ANNEXa-I publication? I think that's another really big, outstanding question for me.
Yeah, it's really difficult. It's like, who do you trust more? Do you trust these larger real world studies versus industry sponsored data? Like there was this meta-analysis by Gomez, and they had like almost 4,000 people in some of these different arms. And then for just the hemostasis arm, it was 1,500 patients, and they showed like no difference in any mortality, thromboembolism, effective hemostasis outcomes, except that 10% that always shows up. But like, big studies, real world data, no difference. AstraZeneca, depending on which study you look at, like the Dobesh one, pretty large difference in outcomes. And the only thing I will say could be a difference between those two is those AZ funded ones. The people that are enrolled are known to have a recent dose of their 10A inhibitor versus these real world ones. We don't know when their last dose was. So maybe they're, subtherapeutic. There's nothing on board, would inflate the efficacy of PCC and things like that. So, that's the only kind of devil advocate side you can say for these AZ funded ones is, they know that patients are on a drug. They know there's a therapeutic level in there. And then when you compare reversal versus reversal, one looks better than the other.
So one of the other things that's going to come from this, let's talk about some practical application, because there's some people here where this is going to be on your formulary, like it or not. You're going to have docs arguing for it, and it's going to come. So what are some practical considerations when you're thinking about this? And instantly, the first thing that comes to my mind is reconstitution time, right? We have code ICH that emphasizes our quick treatment. And the question is, can we actually give this agent in a timely fashion? You mentioned, Scott, the AstraZeneca sponsored study. So there was actually a 2024 study from our colleagues in New York that was sponsored by AstraZeneca and found that the median presentation to administration time of andexanet alfa being 192 minutes over 3 hours. And what's like the quote unquote metric that we're trying to get in like the code ICH era?
So I think, the code ICH is like 90 minutes. I think most people are pushing for 60 minutes, but that 3 hours, it's hard because those patients could be somebody who comes in the door with a headache. They're sitting in the waiting room for a little while, then they get a room. Well, I still got a headache. Then they go to CT. Then we wait for the CT to get read. Then they have there's a bleed versus someone who comes in as a stroke alert, goes straight to CT. We see a bleed right away. So, I'm not aware of that study, so I haven't seen it. I don't know what kind of patients they had. If that 3 hours was a lot of decision to give it, and then there's a lot of mixing time because we don't have it, so I don't know what the reconstitution time looks like. So, is that more of it took that long to diagnose it, and then I don't know, 20 or 30 minutes to make it and send it down versus PCC having the Pyxis and the ER and they give right there.
Yeah, I think you're going to have some bias towards academic centers again that are going to likely place this and stock this into their automatic dispensing cabinets, as opposed to your community centers that are going to be a lot more formulary conscious when it comes to drug budgets. They're going to probably keep it within the main pharmacy. So you're really going to have some issues with trying to meet those metrics, especially if it drops from 90 minutes to 60 minutes. In terms of vial reconstitution time, I again don't also know that, but in terms of the number of vials, we've seen with PCC through the years, we've been able to get by with less and less dosage. And so that you're talking about anywhere from 3 to 5 vials usually. So fairly quick to reconstitute and be able to essentially just push, which for resource scrapped centers that are boarding and having to look for pumps and all that jazz, it's just one less operational consideration with PCC as opposed to with andexanet when you're having to put this infusion together.
Well,
I know when
it's 9 vials for the high dose. That's a lot of Pyxis space.
Did they change like the manufacturer when it first came out? It was like a crazy amount of vials, and they were able to make the vials a little bit bigger to decrease the amount that you had to dilute.
The concentration went from 10 to 20 milligrams per ml after you reconstituted. So I think it did cut them in half, I believe, because I think it was 10 and 18, but don't.
Yeah. I wonder if they have any plans to like further make either a bigger vial size or, make the concentration just to again, if I was them, I would be trying to we can make this easier on you. If that's a complaint somebody has, you'd think they can just fill the vials or drug.
Yeah, if marketing folks are listening from AstraZeneca, that would be a way to get us on your side because, my question too, you're giving a bolus and an infusion. Can we even make that at the bedside with that being infused for, over 2 hours, sometimes 2.5 if you're doing the high dose, thinking from just a sterility perspective. We've seen these crashing ICH patients in the ED. Thinking about IV compatibility when you're doing the 2-hour infusion, right? They're trying to rush or trying to get the nicardipine started. They have 2 lines. You're trying to get 3% going. Nothing is compatible. That's a very real scenario. And then the lab assay thing is a big one. Is there data to say that we can use any conventional lab assays to test for the presence of this? Because a lot of times, right, we're just guessing. They came from, they were found down. They have this on their med list, and you don't have much information. Do we have info that we can start using other labs to help us there?
So, ideally, it would be specific lab assay for, Xarelto or Apixaban. We don't have that yet. So there's been some studies out there trying to correlate low molecular weight heparin anti-10A and unfractionated heparin anti-10A levels, and they've shown a pretty good correlation to where you get your anti-10A level, you extrapolate that down to what your Apixaban serum concentration would be. And then, there's been some proposals out there of using some different cutoffs for determining, would you consider this person therapeutic or not? Now, whether Brian can comment, because I know he pulls these labs on people and they kind of use, that as a decision point when they have patients presenting.
Yeah, so currently we do not have the chromogenic assays available, but mechanistically, just evaluating anti-10A activity, I'm not sure that there's really, if you were to put them head to head, there's going to be a ton of difference. And so I actually use unfractionated heparin anti-10A assays currently, mostly just for qualitative assurance that the patient has drug on board. Scott alluded to it, but there are some cutoffs that people have utilized to where they have made the decision to reverse or not, or take patients to major surgeries. So usually those are about 0.3 to 0.5 units per ml, which correlates somewhere into that 50 to 90 nanograms per ml range for which is quote unquote therapeutic for your factor 10A inhibitors. And so I haven't got any of my physicians that are comfortable with those values yet. It's mostly just qualitative, so I feel at least better that I'm giving something with at least drug present. But I do think that's something that is going to be emphasized further and is actually recommended within some of the European trauma guidelines for reversal.
All right, running a little low on time. Let's hit a couple of mailbag questions here. So does the time from last dose change the preferred agent? Meaning if they took their dose sooner, would that make you want to choose PCC or andexanet alfa depending on? Unfortunately, we only have the cutoff of 8 hours of that kind of breakdown between when they took their last dose and the forest plot. I think it's one of those where mechanistically it would make sense because you're seeing the peak effect of the anticoagulant. You would see the peak effect of maybe giving andexanet alfa. I would just say use caution because that idea of mechanistically, it makes sense. But then what actually happens in practice, that always hasn't held true in that saga. So I'm not sure. What about you guys? I'm not sure that would necessarily change my idea if someone took it sooner rather than later, as long as they were in whatever window you would consider, anticoagulation still on board.
I probably wouldn't change because you know what you're getting in terms of your, rough thrombin potential with whatever dose you're going to give for PCC. So it's fairly accurate. And like you said, the anti-10A activity doesn't always correlate. And so I probably would not.
I mean, mechanistically, if you made that argument saying, ANNEXa-I and R, it was like peak effect of the 10A inhibitors that give it dramatically reduces. They also have another, they call it a rainbow study, where they show thrombin generation on different serum levels of 10A inhibitors and then different doses of PCC. So the higher the serum level was of a drug, even if you gave 50 PCC, you had very minimal increases in thrombin generation. And so that's another one that they will show saying the PCC doesn't do anything, but we can talk mechanisms all we want. Look at the outcomes, it doesn't seem to change anything. I don't think we're going to get a study. Everyone who took their apixaban and then 2 hours later came in at a gigantic bleed, and then we see what happens. So I think, mechanistically, you can make the argument that ANNEXa might be better, but from a outcome standpoint, I don't know if we know that answer. It wouldn't probably change anything I do.
What do you guys make of the one in the subgroup analysis of anti-factor 10A activity at baseline, where if it was less than 30, which I guess is approaching undetectable, that was one subgroup where it definitely seemed worse. Like it definitely favored usual care in that subgroup.
Well, you could make the argument that those patients don't even need to be reversed at all anyway, assuming they have good clearance of the drug. That's one of those that you potentially, especially if it's a bad bleed, you probably already missed the boat if they're already at 30 nanogram, or there's another mechanism behind their ICH, probably hypertension, and they just happen to be on apixaban. At least that's what I would argue.
Now, I'll also point to that, the doing something through a different mechanism. If there's no drug on board to reverse, you would assume that it wouldn't have any bad outcomes, but maybe it is that TFPI or something like that. There's something else going on increasing the risk for, events.
So the other question is kind of like about what some people might call indication creep, and is, how about using it in traumatic ICH, which was around, right, maybe 10 to 15% of this study, or multi-compartmental ICH? Or do we consider using one agent versus the other? And My thought, this is tough. And this is where the question of how to use prospective data versus the randomized data, because we have the Paul Dobesh study. Time to treatment was around 8 hours, but that was a lot of traumatic ICH. So you would say we do have data, but in our big randomized study, there was very little. So I think that centers will probably apply findings, and it would be pure in ICH, and it wouldn't necessarily matter spontaneous or traumatic. My thought is whatever team you're on, that probably would be like, if you're okay with it for spontaneous, probably for traumatic, and vice versa. That would be my thoughts. What's your thoughts with that question, the kind of using it for other non-spontaneous ICHs?
I actually like the idea of PCCs in this setting, despite what pro-coag study showed with essentially like empiric PCC use. But for traumatic injuries, a lot of times beyond just, your factor 10A inhibitor or whatever antithrombotic you're on, especially with the TBI, there's plenty of data to suggest that factor 7 is dysfunctional or there's increased consumption. And so I like the idea of replacing it in that setting. For the multiple reasons, for, like you said, but I really do think, like you made a good point, is that people are going to apply these findings despite there not actually being that hardened evidence. But I'd be somewhat cautious in doing andexanet in the traumatic patient population, just given that these patients are so oftentimes not able to start VTE prophylaxis because they're going in and out of surgical interventions, and so super high risk. So I think that'd be something that if I were at a trauma center where this was available, I would be making sure that I talk to my trauma surgeons to let them know that this is a extremely risky intervention in that setting because of especially if you don't or do believe in the VTE prophylaxis and then looking at the thrombotic rates.
Yeah, I agree. I mean, if you have there's two different types of trauma. It's like grandma slipped and fell, hit her head on the sidewalk versus someone in a head-on MVC. The person in the multi-trauma, I think that Brian's right. Like PCC is more of a more shotgun approach. Like it's hitting a lot more things to potentially help the person during their trauma-induced coagulopathy versus you just give ANNEXa to that person. Yeah, you're potentially just stopping the blood, the anticoagulants effect on hemostasis, but everything else is still going on. So, if someone slipped and fell and hit their head and that's considered a traumatic ICH, that's different than someone getting ejected from their car. And, there's a lot more trauma going on. So, that person that gets ejected is not going to be able to start VTE prophylaxis anytime soon. They're going to be in the OR a bunch of times, long bone fracture. I mean, their risk of VTE is so high. Then you throw on ANNEXa and it's like, I don't know what's going to happen. But if someone slipped and fell and hit their head, I think that would still be a reasonable person to consider ANNEXa if that's in your shop. And in terms of indication creep, like if this is on your formulary, the cat's out of the bag. Like,
yep.
CS is 6, and if you're the pharmacist talking to neurosurge with someone with a bleed, be like, well, the GCS cutoff is 7. I don't think we can do this. They're going to tell you to, F off. Like we're going to do this.
The nicest way they'll tell you.
The other thing too is looking at the traumatic patient population is all the transfusion requirements too. Like, so, you're doing component therapy. You've got, how does that interact with all the different sub-mechanisms of andexanet and sort of the thrombin generation and platelet aggregation that you could see? Because more so with trauma, you're gonna probably transfuse in a component therapy and give more platelets than you would a isolated non-traumatic ICH.
And I think it's neurosurgeons, less trauma surgeons driving the boat on some of the effects of this, at least kind of anecdotally. All right. So closing us out, I thought this would be kind of fun. Instead of kind of like a take home point, our conclusions are going to be what's our 1 to 2 liner, or what's our kind of takeaway at a P&T committee? If you're talking about andexanet alfa at your P&T shop, what's kind of your ultimate message? So Brian, why don't we start with you? What's your message to your pharmacy and therapeutics committee?
I'm stealing Andy Webb's line, and I'm stealing you're trading short-term wins for long-term uncertainty.
Simple. Hammer dropping. All right, Scott, what about you?
I would just show side by side the two slides of outcomes from that Gomez meta-analysis with a couple thousand people with everything is the same except clot risk. And then the ANNEXa results and be like, this one's bigger, this one's real world, this one is RCT industry sponsored. Who do you believe more? And, we can talk about hemostatic efficacy. We can talk about cost. Long-term outcomes are no different. So, what is the most important thing? It's like that, which endpoint do we care about the most? And if you're coming from the pharmacy world, it might be outcomes and costs. If you're neurosurgery, it might be hemostatic.
Do you have one? I'm putting Todd on the spot, by the way. He did not get any heads up on this question ahead of time.
Sure. Well, I think just looking at the results of this trial, and I think you take the overall results, it's not clear that it supports, if you say patients showing up that meet eligibility for this trial, do the benefits outweigh the risks? And it's not clear that the benefits outweigh the risk for that broad population. You're exchanging a benefit on a surrogate endpoint for meaningfully higher thrombosis risks. So I think if it's an all or none question, I think it might argue against, just using it broadly in this population. What I think is needed is additional research to say there are likely patients in this trial who would benefit, and there are patients who are going to experience the adverse effects. And so additional analyses to understand treatment effect heterogeneity, both on the benefit side and the adverse effects side, is what's needed to kind of use this in the real world in an effective way.
And using this in the real world, and that's kind of one of the biggest, one of my big take home messages, because I think the big question is, do we have the operations capacity to ensure this high cost treatment is given in a timely fashion to patients who could actually benefit from receiving it? You got to have a clear protocol to ensure it's safe use. Because if you're just giving it out, I think you'd argue the risk may outweigh the benefit, rather than if you're clear, calculated, have a protocolized approach. I think it could. But I think the other thing that is under recognized, and I'm not saying it's a reason why you shouldn't change. We'll kind of end with this. We hate change in medicine. It's not fun, right? And so how many of us, we have our anticoag reversal, right? It's a well-oiled machine. The nurses know what to expect in the ED, right? If you have this brand new, very high cost, right? Because the first time you use it, you tell the nurse, like, oh my gosh, like this is like really expensive, so be careful, right? Then the nurse it's just like kind of a downstream effect of that, right? So I'm not saying new is bad. I'm just saying when we're thinking of something with time-based treatment being so important, kind of have to keep that in mind. But we have literally deep dived. We did our Titanic excursion. We're making our way back to the surface. You can find all three of these friends, dudes of the pod, on Twitter at Gilbert PharmD, at PCC_PharmD, and at Miano81. So Todd, Scott, Brian, appreciate you guys coming on, sharing your insight into this topic. I think there's going to be a lot of people that learned a lot from this. So appreciate all you guys.
Yeah, thanks.
Yeah, thanks for having me.
Thanks for having us, Nick.